everyone. My name is Hai Liang. I'm the moderator for this session. So today we'll have our sixth session. Today we have Dr. Ang Chin Wee, who is a UMMC colorectal surgeon. Okay, I've heard very good things from your supervisee, I think, Nurin.
Okay.
Yeah, and a lot of the other surgeons also recommended me to find you lah. So that's why I messaged you. Okay, so today we have acute abdomen. So, doctor, do you want to introduce yourself or anything?
I think you introduced already.
Okay.
So a bit of a background. I was never trained in Malaysia. So I came back to Malaysia a year and a half ago now. So a lot of the teaching and training, undergraduate and postgraduate, is a bit different compared to what it was like in the European countries. So I think what has done is to try to adapt and adopt certain good teaching methods and technologies. So I think so far, whoever that's been with me before, the third, fourth, fifth year, you will know that I might be a bit different when it comes to group teaching or discussion. But we'll see how we get on today. So I think what I would like for this session is to have a bit more interaction and also use a bit more of a higher level thinking, because that will be the most important thing when you come to a clinical practice. So you should start using your brain from the very beginning rather than just remembering the facts, because a lot of the clinical scenarios are very much you have to use analytic skill rather than knowing the facts, if you know what I mean. Okay, I think we should start first, and then we can see what question we can generate from the case. Okay.
Okay, so just a bit of warm up. So next slide. Okay, so this is the table that I've constructed based on my reading from Browse. So, doctor, looking at this table, would you agree, or do you think it should be more specific?
I think generally that table is quite useful to start off. You need to know the basics. Those are very basics, but do remember it's only a basic guide, because, for example, patient with appendicular or cecal tumor, they don't always necessarily come in with lower abdominal pain. They can also come with a periumbilical pain or even upper abdominal pain. So just bear in mind that. So in clinical practice, it's all based on probability. Okay. So if the patient comes with a lower abdominal pain, then the probability of appendix, cecal, bladder problems are higher than the others, but it does not automatically exclude other things. All right. So this is only a basic guide for you to work out the probability, what's more likely, which is why we never say it's 100% this or that. Yeah. It's only a probability. All right.
Okay, so moving on to the next slide. So, okay, so from what I've read from Browse, it says that the two most important things of acute abdominal pain is the site and the character. Do you agree, doctor?
In a way, yes. Yeah. So those are the basic starts. When you take a history, you need to work out, those characters of pain, the sites of pain. So those are the most important facts. It would point towards where most likely the problem is. All right. But again, I'm going to mention once again, it doesn't always mean that's what it is. Have to think broadly. Okay. But it's a good start.
Okay, so for example, maybe an appendicitis can come with a colicky pain. Could it happen?
Well, it depends. So if it's just a simple appendicitis, usually it's not colicky abdominal pain. It's more of a constant, progressive, gradually getting worse over time. Okay? But if you remember the anatomy of the appendix, it doesn't always lie at the front of your abdomen, right? It can be retrocecal, it can be towards the pelvis, or it can be going all the way right up to the upper quadrant. So which is why the presentation can be a bit variable. Yeah. So that's what I mean that yes, most patients come with rectal fossa pain. The first thing you think about is appendicitis. But if it goes to the lower abdomen or upper quadrant, it does not rule out completely this is appendicitis either.
I see. Oh,
Yeah. So just bear in mind that that's what I mean. You have to work on the probability side. That most probable diagnosis, rectal fossa pain, yes, appendicitis. But if you think of the anatomy, it goes back to the basics. Where else the appendix can lie in the abdomen.
Okay, so I think that's all for the warm-up. So I think we can go to our first case. Oh, this one I think we can just skip this one. Okay, so the first problem. So Mr. Muhammad is a 65-year-old male presented to the ED with one-day history of severe abdominal pain. Okay, so this is obviously an acute abdominal pain. So let's just move on. So for the presenting,
yeah. Can I stop you there? Before you
sure.
move on, go back to the slide. So when you are when you graduate as a clinician, whether you're a houseman or an MO or a specialist, that first prompt is very, very important. So you have to act as a detective. All right. So when you have that first prompt of a man, that age group, with a very simple presentation symptoms, then straight away you have to already have a list in your mind. What could be the differentials from there? What would be your differential diagnosis from that first prompt? Okay. So always think that you're a detective in that scenario. You have very limited clue, but it doesn't mean that you can't work out differentials from there. Okay. So I want you to think about, from that clue, the first prompt, what can be the problem? What can be the differentials? Give me a list. It can be 5 to 10, differential diagnosis from just that list. So your prompt is 65-year-old, a man, fairly short history, and severe abdominal pain. Okay. So what are the conditions that present very acutely in the 65-year-old man?
Okay, so I think we can open to the floor. Anyone wants to try? Tang Jingwen said mesenteric ischemia.
Yes, possible. Yeah, as one of the potential differentials.
Okay, any more?
Intestinal obstruction.
Sorry?
Intestinal obstruction.
Yes. Okay. So this is an only example, all right? You got to have that list in your mind already. So far, you can think of 2, right? So your subsequent history taking would also need to focus on these 2 differentials. How do you include or exclude those list of differential diagnosis in your head? Understand? So that's how you have to work as a detective, with clues coming over time when you start taking history. But you got to have some clues, differential first, before you proceed with the history taking. Because if you just take the standard history taking, like textbook, at the end you will not be able to come up with a sensible differential. It will be another 10, 20 potential differentials, but then you haven't quite asking specific questions to exclude whether this patient is obstructed or ischemic bowel. Okay? So it's slightly different to the usual way you're taught, okay? Because it's a higher level of thinking you need to start doing from the beginning also. Apart from learning all the facts, but it's a thinking process, reasoning skills. Yeah, you guys know about reasoning skills, right?
Yeah.
This is where it starts, the reasoning skills from the beginning. Okay? Right, let's move on.
Okay, so doctor, you mentioned about the list, right? Noreen, can you go back 2 slides? Okay, so is it okay if we have all these things in our mind ready to talk about? Like the
Yes, correct. You got to have those differentials in your mind. For example, let's say sigmoid volvulus, for example. Okay, so Do we think the presentation is very short, very acute?
Yeah, it's very short, very acute. Is it?
Actually, it's usually quite prolonged history.
Oh, okay.
Yeah, patient would have had some slow progression or problems. They don't usually come with a 1-day history, very severe, very quickly. Sigmoid volvulus is actually a slower onset over a few days or even weeks before they get into these kind of symptoms. Okay, which is what I mean by, you got to have that list and then you worked out and then you exclude one by one when you take the history. And then you will come out to, at the end, with a more sensible differential diagnosis, one, and then one or two more as a potential other differentials, rather than give me a list of 20, which is pointless, right? Because you can't treat 20 diseases in a one patient. You can only treat one or two at that point of time. And you have to pick which one you think is the most likely. Okay? So you are going sort of slightly more forward thinking in a scenario rather than taking all the facts and then worked it out what it could be. And then you might be missing a lot of clues already or details in the history taking, which is what usually happens in many people, So I'm trying to get you to think slightly in a different approach. Okay? And so that approach is a very detective-like. Okay, right.
Okay, so we can move on to the next two slides, presenting complaint. Okay, so let me just read off the presenting complaint. So the patient has 1-day history of a generalized abdominal pain. The patient could not localize the pain. The character of the pain is severe and constant, and patient describes it as being cramping in nature with no radiation anywhere else. Pain score is 10 out of 10, so it's quite severe. Relieving, exacerbating, don't have. So the onset started when the patient woke up from sleep in the morning, and the pain has been there and this severe and this constant throughout until the presentation to the hospital. So the presenting complaint is also the pain is also associated with constipation, anuria, reduced oral intake, and abdominal distension. So from this presenting complaint, what do you think, doctor, from this?
Hey, you're asking me. You should be asking yourself and your fellow colleagues, what do you think that you can exclude the differential wise that your pathologist slides? It's not exhaustive, but it's a good start. So from this, you got 6 lines of clues. All right. So what can you exclude and what can you include in the differential so far? So again, it's telling you severe pain, it's cramping, and patient wake up from the sleep with the pain. Okay, that's distension. But if you look at it, right, when you take history, you got to work out what are the specific clues and what are the very, I wouldn't say useless, but these are very generic symptoms that it doesn't really help you in come to conclusion of the diagnosis. So for example, things like reduced oral intake, is that really going to point towards any differential diagnosis?
No, not
It doesn't, right? Because anybody's not well with whatever symptoms, they're not going to eat. Okay, whether you got appendicitis, whether you've got diverticulitis, whether you have heart attack, people wouldn't eat because they just don't feel well to it. There's no appetite. Okay, so those symptoms you got to work out what is good symptom clues. What are the one that is a bit like, okay, yeah, it would just happen anyway regardless. So it's good to know, but it doesn't quite help you. Okay, so when it comes to abdominal thing, abdominal symptoms or abdominal signs, abdominal distension is very important. Okay, constipation, if it's 1-day constipation, do you think it's going to be important? No, it doesn't, right? So this is what I mean by you got to have that forward thinking already to exclude and include certain clues that you think you need to ask further. Certain clues is just not going to help. You just need to ignore that. Because remember, your history taking station in your exam is time limited. You can't be asking in detail every little thing. You got to pick whichever one that you think is going to help you when it comes to diagnosis. Okay? And again, it's all about reasoning skills coming, from the very earlier on. Yeah? So let's go to the top again. So 1 day history, generalized. Again, very short history. Generalized means everywhere, right? Okay, if it is everywhere, the pain is everywhere in abdomen, what do you call that in medical term? So you have to start thinking of this is generalized peritonitis. Correct or not? Because the patient is telling you the pain is everywhere and is very severe and is very short. So straight away, before you even examine the patient, you have to think, does this patient have generalized peritonitis? Okay?
Yeah.
Now, if it is generalized peritonitis, then straight away, what do you think that could be the differential?
Perforated organ.
Perforation. Okay? So from the perforation, what are the potential differential diagnosis patient can present with perforation? Common things, like 65-year-old man in Malaysia. What are the common things?
So anyone from the floor wants to answer? Peptic ulcer, Lu Kim Ki said.
Correct. So first thing to think of is already, has this guy got perforated peptic ulcer disease? Okay. So what are the history then in terms of the peptic ulcer perforation? What are the other clues that might point towards that you have to ask already? What's related to that? So yes, you got to then think of the risk factors, right? Has this patient had risk factors for developing peptic ulcer disease, and then lead on to perforation acutely? So generally, people have a bit of an intermittent epigastric discomfort, right? Before or after eating, that sort of history, and also whether they take NSAIDs off and on over the counter, whether they previously has had peptic ulcer disease diagnosed before. So you have to think about the risk factors already for that. All right. So peptic ulcer perforation is one of the differentials. What other perforation can it be?
What other perforation? Colon cancer, Ong Yi Chen said.
Well, you just have to say colonic perforation or bowel perforation, right? Yeah. So before the bowel can perforate, what do they normally have? Before a patient had a perforated bowel, they need to be obstructed first, right?
Yeah.
Yeah. So if they were going to develop obstruction, how long do you think the history would take before they come to perforation? It's going to be a long while, right? It's going to be, you're talking about weeks. There will be no bowel motion, no flatus, gradual abdominal distension, vomiting, or without vomiting sometimes, but distension for quite a long period of time, a few days at least, and then severe pain perforated. Okay, so then your history taking will be, has this patient had progressive distension abdomen over a few days with no bowel motion, no flatus? So that will be your history taking already. You understand? So this is what I mean by you got to have that differential first, and then try to work out what do you need to ask further, whether to include or exclude some differentials that you have. Okay, because without that differential list in your mind, you will just be asking very vague questions, not really focused questions. And then somehow, if you're not careful, you will be misled to a certain area. For example, this patient mentioned about constipation, and then you take another 5-10 minutes asking about constipation, and then you're wasting your time already. That you're not really going to be able to come to the conclusion later on. Okay? So that's generally what I see when I take 3rd or 4th year or 5th year in a group in a bedside teaching. That's usually what happened, because they're not able to work out at the end when you present to me the history, the conclusion is always wrong. It's because the focus history is not there. Okay? So try to work in that manner as soon as you can. It would help later on. Okay? Right.
Okay. So
Should
would
we
you
carry
like?
on?
Okay. Next. Okay, so some elaboration on the associated symptoms. So constipation, okay, 1 day history of constipation associated with a lack of flatulence. The patient attempted to pass motion several times throughout the day, but couldn't. Then for the abdominal distension, also 1 day history. Patient said that his abdomen is swollen compared to 3 days ago. Anuria, also 1 day history. The patient didn't drink much water, but he still drank a little bit. No nausea, vomiting, so that's okay. Poor oral intake is about 3 days. He still could eat, but it's reduced due to some abdominal discomfort that he described as abdominal discomfort, like fullness, but no pain or change in bowel habits during the time until 1 day ago where he couldn't pass motion. He denies any nausea, vomiting, any prior hematochezia, no loss of weight, no fever, no night sweats. So, okay, so those are the associated symptoms.
Okay, so from that list of so many symptoms, right? Where do you go from there? Which area do you focus on? You think that it's more important, certain symptoms that you can just forget about it because they're not very specific. Because you asked quite a lot already, about your associated symptoms. So then in your head, you got to work out which are the symptoms that you can just discard and which are the symptoms that you need to focus further. Because the patient will tell you all sorts,
Mm-hmm. So maybe.
Do anyone want to contribute, maybe? Do we have final year?
The final year students on the try?
Yeah, because final year, you're coming to the end of your medical school, so you have to start already thinking about how to make a proper differential diagnosis at the end, right? So this is what will come an exam.
Maybe the 4th years can try, because they are
Can.
almost the end already. Also.
Yeah, can also.
Anyone?
Okay, don't be shy.
Tang Jingwen said maybe you can focus on constipation and dyspepsia.
Okay, why do you think constipation is important in this case? And how do you define constipation? Do you know the true definition to label somebody as constipation?
Good morning, doctor. I was thinking perhaps the patient may have obstruction somewhere. So I think constipation is important, and also, I'm not very sure how to define constipation in this case.
Exactly. So use the word carefully, because constipation, if you looked up, the textbook or online, the proper definition of constipation is not just 1 day. Okay, so most people may open a bowel once a day, right? But some people may open a bowel every 2 or 3 days, and that's normal. So you can't say these people are constipated.
Mm-hmm.
Understand? So you have to remember, constipation is not just 1 day. Yeah. So I can guarantee you, how many of you in the chat room now? 50 something, right? So not all of you open your bowel every day. Okay. Some will be every 2 days. Some will be every 3 days. But majority will be on a daily basis. And doesn't mean that then these people that will open a bowel every 2 days are constipated. All right. So from there on, you can tell already that constipation history, you call it constipation, it's not going to be relevant anymore. It's only 1 day. So, if the day before that, the patient telling you, yeah, open a bowel, no problem. Only yesterday, no bowel motion. then you know that bowel habit, that bowel symptoms, you can just forget about it, because it's not going to be helping you later on when it comes to diagnosis. If they're telling you they have no bowel motion for 7 days, that is very important, because that is clearly not normal, and that can be classified as severe change in the bowel habit. Yeah. And constipation is one thing. There's another definition or another terms that you have to know is absolute constipation. And what does that mean?
Anyone wants to try? So absolute constipation, from what I read, is a lack of passing motion plus splatters.
Correct. So absolute constipation, it's completely nothing coming out per anus. Okay. So usually patients have gradual onset of change in the bowel habit, change in the color of the stool, or change in the consistency of the stool, things like that. And that is a gradual development over weeks or months. And then they might become absolutely constipated over a course of 2-3 days, or even 4 days sometimes. But they usually have abdominal distension over a few days. Yeah. So that's why it comes back to this bit of history that you take associated symptoms. You know, no bowel motion for 1 day, abdominal distension for 1 day. So it's not that specific anymore. These are very vague, generic symptoms that can come with any other differentials. Yeah. So if you had, let's say, perforated appendix or appendicitis, you would also have no bowel motion for 1 day. Your belly could be a bit distended also for 1 day, because it's a generic inflammatory response in the abdomen. Yeah. So that's what I mean by you have to then think about, are those symptoms that you have taken from patients, are they any relevant? Not to say they're not relevant, but are they relevant enough for you to focus on that further? Because what I don't want you guys to do is to spend another 5-10 minutes taking a long history on constipation. Yeah, because that will be a wasting of time already in your exam. You can do that normally because you can spend an hour or two with a patient, but in an exam you cannot. You got to focus. Yeah. Okay. So anuria, do you think 1 day history of anuria is anything important?
Not really.
Not so focused, right? Again, because when the patient's not very well, they don't eat, they don't drink. When they don't drink as much, they also have no urine output much. Okay, so again, it's a very vague symptoms. Nothing really for you to go from there. Very short history. Okay, and then poor oral intake, again, very vague, right?
Yep.
Yeah. So again, don't go into poor oral intake history much more. You can ask a bit, but don't waste time asking too much on that. Because remember, always go back to your first clue. 65-year-old man, severe abdominal pain and generalized. And you think from there, this could be generalized peritonitis. This could be perforated viscous. Okay, so those clues that you had for the first 4, it hasn't really given you any potential, differentials at all. Correct or not so far?
Yeah.
You can say your constipation, no flated, where can be obstructed, perforated. But if you know obstruction, perforation, the symptoms of development usually is over the course of quite a prolonged history, a few days, if not a week.
Yep.
Okay. So the last clue, dyspepsia. So it could be the light bulb in your head already. This patient has epigastric discomfort, which would link to generalized peritonitis with perforated peptic ulcer disease. That kind of link. Correct?
Yeah.
Then you can then focus on dyspeptic symptoms a lot more in your history taking. Understand? So that's how the reasoning skills come in. How do you reason every little clues to include, exclude, things like that. Yeah.
Yep.
So it's good to ask all this. No hematochezia, nausea, vomiting, again, very vague. Okay. Loss of weight, all these are very generic symptoms. In your curriculum, in your syllabus, you have to ask those generic symptoms. But to be honest, a lot of times it doesn't quite help you when it comes to differential diagnosis. Good to know, but may not help you. All right. For example, things like fever, night sweats. So what does that point to?
More towards constitutional symptoms, so malignancies.
No. This is a very short history. Remember, 1 day. Well, maybe 2-3 days, given the 3 days of poor root intake, 3 days of dyspepsia, so it's a very short history. Okay, but this patient also has some night sweats and fever in this period of time. Very short history, 2-3 days. So what does that mean? So that usually means that the patient is now septic. Yeah, he has sepsis because of night sweats and fever.
Okay. But this patient don't have the night sweats and fever.
Okay, that's what I mean. That you got to that worked out already. Is it septic or not? Yeah, if he has, then yes, sepsis. And then what would give you sepsis from the abdomen? So you got to link all this together. If no sepsis, then what other disease or inflammatory or infective condition in the abdomen that would not give you sepsis? Okay, so every little clue can branch out a lot further, but try to focus. Okay.
Okay.
Okay. Next.
Okay, so going next. Okay, so this is the patient's past medical and surgical history. Patient had a long-standing hypertension, currently on medication which he don't remember because he says it's not compliant to it due to his forgetfulness. He has done an appendectomy about 10 years ago. No complication associated with the surgery. He also had venous ulcer diagnosed 1 year prior to admission. Recently admitted again 1 month ago due to an infected venous ulcer and discharged with antibiotics and pain medication after dressing was changed. Okay, so looking at this, again, does it look like it's forming to be any risk factors for any condition like we mentioned? So peptic ulcer disease, 1 month of NSAID, could it cause peptic ulcer disease or not?
Oh
really?
yes, definitely.
Yes.
If you take NSAIDs, for more than a course means a week, then you can, yes, develop peptic ulcer disease.
I see. How about the appendectomy? Is that an important history to take?
Definitely, because you already know appendicitis is not possible.
Yep.
Or perforated appendix is not possible anymore, because patients with perforated appendix, they can also present with generalized peritonitis.
Yeah.
Okay, so that's one thing rule out.
Do we need to consider the possibility of adhesions, maybe in this, because he's done some abdominal surgery?
Adhesion usually means obstruction, So do you think the history gives you any clue about obstruction?
Not really.
Not really, exactly. So you already can rule out adhesion obstruction is unlikely.
So hypertension, not really also, I guess, is it?
Well, hypertension is important when it comes to assessing the patient.
Yeah. Okay, so I think we can move on. There's nothing much here.
Yep.
Okay, so also nothing much here. Miscellaneous history would be family history. The patient had no significant family history of any malignancies. Drug history wise, he has taken his oral antibiotics and some pain medication, which he don't remember. No known or food or drug allergies. For social history, he was an ex-army personnel, currently retired for about 10 years. He stays in Taman Medan in a terrace house with his wife and son, but currently both are not around. He used to smoke, but he couldn't really specify how much he used to smoke and how long he had stopped. No history of alcohol or illicit drug use. So the history has ended.
Okay, so from that list, start from the top. Where do you think important or non-important clues?
So the pain medication is one, like we said, NSAIDs, right?
What about the oral antibiotics?
Not sure.
So what does antibiotics do?
Okay, I know what you're talking already. So it kills off the bacteria in the, what do you call that, in the colon.
Okay,
it should
so I saw somebody called Humira. So you said antibiotics can mask infection. That's exactly it. Okay, so when it masks infection, what does that mean? That means the patient comes in the later stage of the problem. Yeah, in other words, though he says 1 day history of pain, about 2-3 days you're not so well, but it could be a bit longer than that. The symptoms, it's been masked by antibiotics because it's partially treated. Okay, and Adrian and Chunying also said, yeah, C. diff, pseudomembranous colitis, yes, it might need to come to one of your differential diagnoses or this C. diff colitis. Okay, but if you think C. diff colitis could be one of the differentials now because patient takes oral antibiotics, what are the symptoms for C. diff colitis? Usually they will come to presentation to us. So usually is severe diarrhea. Okay, rather than acute severe pain. So diarrhea is usually the first onset, and the diarrhea can be 10-20 times. Okay, so straight away this patient does not have severe diarrhea. In fact, no bowel motion for a day. Okay, so you can pretty much exclude that C. diff colitis already. Don't even have to think about it because this patient does not have that symptoms. All right. So that's what your thinking process should just follow like that.
I see. So anything else you'd like to highlight in the history, doctor?
Let me think. I think so. The usual thing about alcohol, no smoking. Okay, that is a standard question you have to ask. Alcohol is particularly important if you think this peptic disease it's coming to place. Peptic ulcer disease, because alcohol, smoking, they are associated with peptic ulcer disease. Okay, so it's part of the risk factors.
Okay. Okay, so I think we can move on if there's nothing. Okay, let's just move on. So the physical examination is as follows. General inspection, the patient is alert and conscious but in respiratory distress. So oxygen was given via nasal prong for the flow of about 3 liters per minute. Vital signs, the patient is a bit tachycardic, 104 beats per minute. Respiratory rate is 24 breaths per minute, so tachypneic. Temperature is 37.9 degrees Celsius, borderline. Blood pressure is actually hypotensive, so 105 per over 71 millimeter mercury.
Okay, so, from there, what do you think this patient states current in? So we mentioned about the word sepsis, right?
Yeah.
Okay. What else? What are the magic, the buzzword that you have to say? Oh, apart from sepsis, this patient is in septic shock. Exactly.
Hypovolemic.
So, correct. Remember, this patient has not been compliant to his antihypertensive. All right. So, a 65-year-old man, if he's previously diagnosed with hypertension and does not take his medication, what do you think his normal blood pressure is?
Should be higher.
Should be a lot higher, right? Should be at least 130, 140, if not 150. And in fact, it's only 105 systolic. So that already tell you he's in shock. Okay. On the other hand, if this is a young lady, 18, 20 years old, with a blood pressure of 105, you would say, well, it can be normal, isn't it?
Yep.
So that's what I mean, that the non-compliant to antihypertensive is a very important clue. Even though the blood pressure is 105, you could say it's normal to certain people, but it's actually not normal for this patient.
Yep.
Yeah. So when he's Taki 104, the speed rate 24, temperature 37.9, you already straight away think, okay, this guy is in trouble. He's in septic shock. Okay. So you're in a serious problem here, dealing with a serious problem. Yeah.
Okay, so moving on to the abdominal examination. On inspection, appendectomy scar can be noted on the right iliac fossa. Gross abdominal distension is noted also. Tenderness upon light palpation at the umbilical region, and generalized tenderness on deep palpation everywhere. No mass can be felt. Rebound tenderness is not noted. Percussion at the right intercostal margin to determine the liver borders cannot be, it's just no difference. So liver border could not be determined. Negative shifting downward stairs and no bowel sounds can be heard. So from here again, I think it's quite obvious really lah. What's happening, I think.
Well, if you look in detail, tenderness upon light palpation at the umbilical region, that is the central region, but generalized tenderness on deep palpation. Okay, you've highlighted no rebound tenderness. That means, so if you were to say this patient had generalized peritonitis, it should be rebound tenderness, right? And it should be tender on light palpation everywhere, generally. So
Okay.
have this patient had that?
No.
No, right? So do you now think this patient had generalized peritonitis or not?
No.
Sure.
Actually, from what I've read is that rebound tenderness is just a sign of more severe tenderness, but cannot rule out lah, I think. That's
So
why.
like I said from the beginning, there's nothing 100% in clinical medicine. Okay, so the definition, the textbook would say in generalized peritonitis or in perforated viscous with generalized peritonitis, you would have pain everywhere, pain on light palpation generally, and rebound tenderness. Correct or not? To justify the word peritonitis.
Yep.
Okay, but in real clinical practice, it does not work like that all the time. And there are many reasons to that. Okay, one of the reason is there's gross abdominal distension. So that could be because the bowel has gone into ileus because of inflammatory condition of any sort in the abdomen. So imagine that when your bowels are distended, it actually hides that inflammatory peritonitis. So that's why you don't get the generalized peritonitis on palpation, because the bowels are actually in the way.
I see.
That's one possible reason. The second reason is, again, it goes back to your antibiotics. Yeah, so because the patient is somehow treated in a way, partially. So the presentation is not typical anymore.
Okay, yeah.
Okay, yeah, so that's what I mean by nothing is 100%. You got to have that mind still, that it's still tender everywhere, though not generally peritonitic, but it could still be perforated viscous. It could still be generalized peritonitis.
Yeah.
It's just your clinical examination doesn't quite fit into that 100%. But as you said, nothing's 100%.
Yep.
Okay.
Another thing, doctor, so I like to highlight the liver border could not be determined. So So in the textbook, it says that if you cannot feel the liver, it means that the air has escaped from a perforated viscus, and therefore that's why you cannot feel the liver border. But is that relevant in clinical practice or?
Generally not. Liver border, if you can feel it, if it's measurable, is useful. But if it's not felt, then it becomes a fairly useless clue. Because a lot of the liver border, whether it's palpable or not, it goes with the patient body habitus.
I see.
So it's not that easy always to feel the liver border. So that's what I mean, that when it is easily palpable, when it's very measurable, then it is a useful sign. When things are negative, it becomes a bit like, is it negative because of other factors?
Yeah.
Okay. So that goes with liver border.
Okay, got it. How about the absent bowel sounds, doctor?
So the absent bowel sound, it's a bit non-specific. You know, to hear bowel sounds, you got to be in a fairly quiet environment, and you got to put your stethoscope for at least how long?
30 seconds?
Yeah, at least. Okay. So imagine that if you work in a clinical environment, especially in emergency department, you know how noisy it is around.
Yeah.
You know, especially when the patient is in septic shock, they'll be in a resus room. And the resus room has got all sorts of monitoring, okay, with all the beeping sounds and all sorts of sounds. So you're not going to be able to hear the bowel sounds very clearly. So that's why the bowel sounds becomes a bit like not so important clues.
Yeah.
Which is also another reason why you see a lot of general surgeons don't even carry a stethoscope. Because they're not a very specific things, but it is somehow useful in other scenarios. When you think this patient is obstructed, that you want to differentiate, is that a tinkling bowel sounds? That's one of the useful signs. The other scenario is that when you have operated on a patient, on the bowels especially, you want to know whether the bowels is actually working or they're in ileus.
Yeah.
So those in those scenario, then the bowel sounds become more relevant. Okay, but in other acute presentations for other conditions, you know, for example, things like appendicitis, generally patients have a certain degree of ileus because it's a inflammatory condition in the abdomen. So you might not hear bowel sounds as well. Or it doesn't mean the patient is obstructed. The patient might be having some degree of ileus because of other things like appendicitis, diverticulitis. So is that going to be important then? No, it doesn't really add to anything.
Okay,
Okay,
understood. Yeah.
but it's part of the examination you have to do in exam. Okay, but in real practice, I can tell you, not many people use stethoscope.
Okay, got it, doctor. So can we move on?
Yes.
Okay, so I'd like to try and summarize this case maybe. So Mohammed, 65-year-old male, present with a history of hypertension, venous ulcer, and previous appendectomy, presented to the hospital with a severe generalized cramping abdominal pain associated with, okay, maybe I should change that, no constipation, no. How should I summarize this case, doctor? Is this summary sufficient?
Yeah. So if this is the OSCE station asking you to take a history, okay, in your summary, it should actually be one sentence, if possible. Okay. So how are you going to put it in one sentence? Or I'll give you two sentences. Anybody wants to try?
Yeah.
For those with me before, you should know already, right? I emphasize a lot on your summary. How do you summarize at the end?
Anybody want to try?
Okay, sounds like nobody wants to try.
Yeah.
So if I were to do it, okay, so again, it goes back to your differential diagnosis, right? So what do you think is the most likely diagnosis so far? Just from the history and the limited clues in the examination. So we worked out that this guy had maybe a perforated viscous, right?
Yeah.
Given the short history, severe abdominal pain associated with, the associated symptoms that you got. What's the most important one? It's the dyspepsia for 3 days, isn't it?
Yeah.
The rest are fairly sort of vague and generic. Okay, so your most likely at the top one will be perforated peptic ulcer disease. That's the most at the moment. All right, but it doesn't mean others are not possible, right? Things like acute diverticulitis or perforated diverticulitis, things like that. So that could also be possible. Okay, but in your summary, you should try to put the differential diagnosis in. Okay, you should say 65-year-old man presented with a very short history of generalized abdominal pain with preceding dyspeptic symptoms, and examination showed this patient is in septic shock with also generalized abdominal pain, and therefore my top differential diagnosis is perforated viscous, most likely peptic ulcer perforation.
Okay.
That's one sentence.
Yeah.
Okay, and the examiner might ask you, what other possibility then? What else can it be? Then you only say, okay, my other differential could be this, and that.
Yeah.
Okay, so you see the summary should be a very quick snapshot on what you've gathered from the patient for you to be able to synthesize and then come to a differential at the end, which would make sense because you linked some clues here and there.
Yeah.
Okay, because what generally the focus is in exam is the focus is not actually you must get the differential diagnosis correct. That's not the focus. The focus is how do you synthesize, how do you make out from your history and examination and then come to a sensible conclusion. Even if your conclusion is wrong, but how do you come to that to make that conclusion? That's what is the focus in your teaching and in your clinical attachment. Because none of us will get it right 100% when we first take history. When you first examine a patient, nobody actually can get everything correct from the beginning, which is why we then rely on radiological investigation, right?
Yeah.
But from just history and examination, you should be able to reason, what are the clues you've got, and to be able to understand, make a conclusion out of that clues. So that's what we want to see.
I see. Okay. Yeah, I got it. So we can move on to the next slide.
Yeah.
Okay, so these are the differential diagnosis. I was hoping someone would try, but yeah, we have it ready, I think. Maybe differential diagnosis, anyone wants to try? What other differential diagnosis you think is possible? Anyone? Hello?
I think we shall move on to the next case.
Yeah. No. So I have the investigation a bit. So can we just move on to the
Okay. Sorry, are we just doing one case?
Yeah, I think I promised you 1 hour, so I think 1 hour.
Yeah.
About 11, we should finish that. Try and finish it as soon as possible.
Okay.
Yeah.
Yeah.
I think one case enough for this.
So just hang on. Dang Chin Wen said mesenteric ischemia. So do we think that is a potential provisional diagnosis or differential diagnosis?
Good morning, doctor. I was thinking like because of this patient age and also the history of hypertension. So, and also on physical examination, it's also quite vague. There's no specific symptoms. So I was thinking the out of proportion pain suggests the mesenteric ischemia.
Okay, very good. I think you definitely have the reasoning skills there, that you would say this patient has out of proportion pain and the clinical examination is not quite, the generalized peritonitis, the rigid board kind of examination, isn't it? That's what the mesenteric ischemia usually would have, some soft examination, a bit painful here and there, but not all generally peritonitic. So generally that's what mesenteric ischemia is. Okay, but what other things in the mesenteric ischemia that you could ask or you could observe in the clinical examination that would point towards maybe mesenteric ischemia is more likely?
Anybody want to try? Okay, maybe I go first. Maybe you could consider thromboembolic event, maybe AF.
Yeah, okay, that's one of the important examination things that you have to look for, whether the patient is in AF. But again, AF can be because of,
The inflammation.
no,
No?
it can be because of sepsis.
Oh yeah,
Yeah, sepsis can cause atrial fibrillation. So it's maybe not in the AF side, but if the patient has AF, then definitely you have to think, then has this patient had mesenteric ischemia? Okay. What other things that you could think of in a maybe history taking or examination, it could point towards mesenteric ischemia?
Previous history of. I keep answering. Everyone wants to answer or not? Anyone wants to answer? Okay. Anyone else? Jingwen, maybe you sound like you've read about mesenteric ischemia. Do you want to give anything else?
Could maybe history of like stroke or coronary heart disease.
Yes. So in the history taking, if mesenteric ischemia is one of your differentials, then yes, you have to ask a lot more in other link of the diseases, like you said, stroke, heart disease. So they are always linked. Yeah. So that's why when I talk about focus history, that's why you have to ask those things, because I think you guys been taught to ask systemic inquiry, right? You have to ask everything from top to toe, correct or not?
Yeah.
But do you think in exam of that 6 or 7 minutes of OSCE, you have that time to ask the whole list of things?
No, not really.
You're not gonna have time. Yeah, which is why it's a focus history. If you think from the presentation, you ask the history patient complaint, you think mesenteric ischemia is one of your potential differentials, then you got to ask already focus one about heart disease, about a stroke, about diabetes, about renal impairment, and all these things are linked. Yeah, very rarely you get patient with young and fit, 40, 50 years old, or even 60s, no other past medical history, suddenly present with mesenteric ischemia. That's not very common at all. They usually already have some other problems in the past. Okay.
Yep.
And then in the clinical examination, what would a typical mesenteric ischemia look like? First thing is, like you said, the pain is out of proportion. The second thing is the patient seems to be moving around, wiggling around in pain. They can't find a comfortable position. Because mesenteric ischemia, usually patients have no generalized peritonitis. They just have that severe colicky pain.
Yeah.
That's why they tend to just move around in bed, cannot find a comfortable position. It's a bit like your ureteric colic, If you had a ureteric stone causing severe pain, they're a bit like that. They just can't find a comfortable position. Okay.
Yeah.
By the time they don't move around, usually means they are already perforated or all the bowels are already infected. It's too late already. That's why they lie still. Because when they move, it hurts more. That's why they don't move anymore. So that would not be mesenteric ischemia. It will be mesenteric infarction.
Yep. Okay.
You understand the difference, right? Yeah. So that's why the mesenteric ischemia patients, it presents with the different stages, and every different stages, the symptoms, the signs are different. Okay, so in the initial stage, they are wiggling around. You know, they don't look sick, but they just somehow something's not right, and you can't put a finger down because they just tender somewhere here and there, not really specific. So that's the initial stage. But a late stage, they can look at what your patient had already perforated or infected completely. All the small bowels are infected. They will just lie still because they are in deep trouble. They are in septic shock, renal failure. You know, all the multi-organ failure comes in.
Okay, so aside from that, Ng Junying said perforated bowel due to bowel obstruction as a differential.
Correct. So when you do that as a differentials, you then have to think any bit of a history would point towards this patient had bowel obstruction.
I think maybe it's the constipation that, but the short history would suggest otherwise lah.
Correct. So 1 day history does not give you constipation. It does not give you obstruction. Yeah. So I mentioned earlier, obstruction develops over a few days.
Yeah.
Yeah. And then you have to think about obstruction. Is it a large bowel obstruction or is it small bowel obstruction? Okay. Because the presentation is completely different. The signs are completely different. The symptoms are completely different, whether it's a small bowel obstruction, large bowel obstruction.
Okay.
Okay. So the history taking doesn't really point towards any clues about bowel obstruction at all.
Yep.
But that, as I said, that doesn't mean that it's 100% exclusion. The reason is because patient might not tell you everything that's true.
Yeah.
Yeah. So although you have that in your mind, could this patient have perforated bowel because of obstruction? But it's become a less likely. Less likely does not exclude. Yeah. Which is why then you rely on the scans to tell you whether this can be 100% excluded. Even the scan can't tell you 100% most of the time. Yeah. But in your summary, if you bring up that perforated bowel, secondary bowel obstruction as your top provisional diagnosis, then definitely you have not actually analyzed your information or your clues correctly. You know, right? You know what I mean, right? So you got to synthesize your clues, your information you got, and then come to a sensible conclusion. Okay, all this needs a lot of reasoning skills lah. Yeah, a lot of thinking process in it. It doesn't come automatically. It comes with practice. Yeah, it may sound quite difficult. You have to know a lot, isn't it? But actually, it's not that difficult if you do it on a regular basis. Understand every clue what it means, and then quickly in your brain work it out. Can that be discarded? Can that be included? And then if you practice that regularly, it becomes a very easy task. Because quickly in your brain you work it out already. You know, it's almost like an algorithm. You know. Yeah. But it comes with practice. So that's what I said, that when you come to clinical attachment, even from a third year onwards, you know, you should start already working towards that sort of mindset about working out reasoning skills and then worked out the different shows very quickly. Yeah. So that's what you should focus on in your clinical attachment.
Okay. So I have just a few questions about the investigation.
Sure.
So looking at the imaging, so we have chest X-ray, abdominal X-ray, CT, and abdomen. So these three are actually fairly commonly seen in UMMC. But I just want to ask, are the rest actually common, and what are their indications?
So when it comes to investigation, again, it goes back to which are the investigation that would help you to come to diagnosis and management. Okay? Because there are many modalities in investigations and you cannot do it all. All right? So if you read a textbook, it will give you many things. But how do you choose which one? Because not all is available in your specific hospitals. All right? And also not all it's really cost effective.
Yeah.
Okay? So obviously you start off with the basic things, with the cheapest things, the easily available things. Yeah? So the easily available would be the basic things like blood tests. It's cheap, it's quick, and it's easy to get, right? But even that, blood test does not mean that you have to tick everything, you know. So let's look from the start. Full blood count, is that important? And why is it important?
Yeah, important because the patient might be in shock, so want to take the white cell count. If it's hypovolemic, maybe you want to take the hemoglobin.
So the full blood count would tell you, is this patient had infection? The infecting markers are there, isn't it? The white cell count, the differential of the white cell count. Yeah?
Yeah.
The renal function test is important because, like you said, the patient might be in shock already. Yeah? Been not well, no urine output for the day. So he might be in renal impairment already. Okay? Coagulation profile, if the patient in septic shock, they are likely in multi-organ failure, right? So the coagulation profile can also go off. And a more important thing is, you're looking at this patient might need surgery, right? So you got to know the coagulation profile. Similarly goes with blood group cross match. So if this patient likely need operation, you got to do that, the blood group. Cross match, you don't do it straight away. You can request for it later on. Yeah, but you must do blood group and save. Okay, so those are very easily available, very cheap, and get it done, you know. But unfortunately, in some hospitals, it's an electronic request. Okay, so do not simply click things, which happens a lot over here, because when it's electronic, you know, people do not take care when it clicks investigation. They just think, okay, this patient might have cancer because, you know, I don't know, something's not right. So just click tumor markers. And that is actually a waste of money because it does not help you and it's very expensive, those tests. Yeah. So just take care of those, you know, every investigation you requested, it comes with a cost. So just think carefully, do you want to waste money doing certain things unnecessarily? Yeah. So when you go to imaging, so the most basic things is the chest and abdomen X-ray, right?
Yeah.
So which other one is more important, you think?
The abdominal.
What does the abdomen X-ray is going to show you? For
If,
this particular patient, you know?
oh, okay. So maybe chest X-ray to see if the, what you call that? Yeah.
So correct. So the most important X-ray, if you can only choose one, is a chest X-ray. Okay. Like Felicia was saying, it goes back to you want to look for whether if there's any gas under the diaphragm. Yeah. Pneumoperitoneum. Okay. Because your history suggested that this patient has peritonitis, perforated viscous, right? So the chest X-ray, well, erect chest X-ray is very important. The abdominal X-ray, when is it going to be useful?
For the intestinal obstruction.
Say again.
Intestinal obstruction kind of presentation.
Correct. So if in the history you think this patient has obstruction rather than perforation, then abdominal X-ray is more relevant. Okay, but in clinical practice, chest and abdominal X-ray comes together as a package. And chest X-ray is also very important because this patient might need surgery. So the anesthetist will want to know what is the patient's lung ventilation, lung function look like. So that's why the chest and abdomen X-ray comes in a package. But some patients are not well enough to have an X-ray done in the radiology department because it's in septic shock. Okay, that means that you got to choose, because abdo X-ray cannot usually be done in the resus. But chest X-ray can. You can have a portable chest X-ray. Yeah.
Okay.
Yeah, which is why then it comes to you now as a clinician to choose which one do you want, which one's more important. So clearly in this scenario, it's the chest X-ray, because you want to know, is the patient perforated? You don't think it's obstruction. So what's abdo X-ray gonna help you? It doesn't really help you, right?
Yeah.
So sometimes you do have to choose. Okay, but usually when a patient, you stabilize them, you give them fluids, you give them some drugs, inotropic support a bit, the blood pressure becomes stable, you give them antibiotics, the sepsis improve, then you can get the patient to the proper X-ray department for the chest and abdo X-ray. Okay, but it all goes back to, do you really need abdo X-ray for this particular patient? Probably not.
Yeah.
Okay. So the next thing is CT abdomen. Okay, in many hospitals, especially if you work in a very rural hospital, you do not have CT scanner. Okay, and the patient might need to be referred, many kilometers away. Some could be 50, 100 kilometers away just to have a CT scan. Okay, so in that scenario, what are you going to do? Patient septic shock, not very well. You can only do plain X-rays. You don't have a CT abdomen and pelvis. So what do you do? So it goes back to your plain X-rays, whether it gives you any clues. And again, it goes back to your clinical history and examination. Do you think this patient has any evidence suggestive of peritonitis, perforation, that you need to do operation rather than wasting time doing investigation? Yeah.
Yep.
So you have to make that judgment. Not always think, oh, from your clinical attachment, all these patients need to have a CT to come to a conclusion. Then you have to refer out. The patient might take half a day to reach to the other hospital. The patient will be dead by then. Yeah.
Yep.
So not all clinical practice are the same, Even though when you read the textbook or when you come to clinical attachment in certain hospitals, this is the practice, and that doesn't mean it's always the only way or the right way. There are many ways. Okay, but in principle, you want to make the diagnosis before you do an operation. Okay, so yes, the CT scan, it's the most helpful thing.
I see. Okay, so I think, do you have anything else to add, doctor?
So barium enema, why is that even in that list?
Oh no, I am just putting it as the list lah, just overall only. It's not relevant for this case lah. That's why I put
Yes.
the mark there.
So what do you think is relevant on that list for this particular patient? So we talk about X-ray, we talk about CT scan. So you have got barium enema, ultrasound, and a colonoscopy. Forget about the CT, MR angiography. Okay, so you got barium, ultrasound, colonoscopy. So all these are fairly easily available. So do you think any of that is relevant for this case? And if not, why? If yes, why?
I think barium enema, no need if there is CT abdomen. Ultrasound.
Okay, let's say you don't have a CT abdomen. Okay, but you can do barium enema ultrasound. Ultrasound is actually very readily available in many rural hospitals also. So
I would say probably barium enema we wouldn't do because we're not really looking at intestinal obstruction.
Okay.
Ultrasound, not sure about that.
Okay. Colonoscopy?
Colonoscopy, also I don't think we should be doing because you can't see anything also in this kind of patient. Plus,
Okay.
it didn't clear the bowel, so not sure if it's relevant or not.
Okay. So barium enema, colonoscopy, these are the very dangerous investigation in emergency setting. Okay, it's a no-no. Yeah. And if patient you think has perforated viscous, generalized peritonitis, never ever do barium enema or colonoscopy. Because barium enema is barium, right? Bariums are actually
Radioactive.
irritative to your peritoneum. Okay, so if you have suspected perforated viscous, barium is a no-no. Okay? Same thing for colonoscopy. If you think patient already had perforated viscous, why do you want to introduce air any further to the bowel? It will just cause more distension and the air might leak out to the abdomen because of perforation. So you can actually cause more harm than good by doing those two investigations. Okay? What about ultrasound?
Ultrasound, I'm not sure. Maybe open to the floor.
Yeah, open to the floor. Any idea about ultrasound?
Ultrasound to look at vessels, looking said.
Okay. Ultrasound, it's very operator dependent, but at the same time, it's very cheap. Yeah. You can just push the machine here and there. The machine is not very big. You can just do it anywhere you want. Okay. So a very good ultrasonographer or ultrasonal radiology, they can actually pick up air outside or fluid. Okay. So ultrasound can be helpful, but it does not give you a very confident diagnosis. So for example, if you are in a hospital where there's no CT scan, just plain x-rays, you can try to get your radiologist to do a ultrasound scan and say, is there a lot of free fluid? Because a lot of free fluid would suggest perforation also, right? Things leaked out. Correct or not?
Yep.
And a good radiologist may also be able to detect air outside the bowel. So that in a way give you some clues that this could be perforated viscous, but it's not gonna be as accurate as your CT scan.
Yep.
Okay. So what I'm trying to say is that if you work in a hospital where there is a CT available, then you do not go for ultrasound. But if you're in a hospital where there's no CT scanner, and if you were to request for a CT, it takes half a day before the patient can get to the other hospital, then by all means, you can use ultrasound to see if it gives you any clue at all. So you cannot completely say no point using it because it might give you some relevant clues. Okay. So ultrasound for appendicitis, Tang Ching-wen was saying, yes, ultrasound for appendicitis, it's fairly a good test in a good hand. It's very operator dependent. Yeah, some were very, very good radiologists. They can look for appendicitis in a slim patient, particularly in pediatrics. Very useful because in pediatrics, if you're not so sure if it's appendicitis, you don't really want to subject a young pediatric patients to a CT scanner radiation. So ultrasound is a very useful tool in young but slim patients.
Okay.
Okay, but in this case, obviously, it's not relevant ultrasound because it's generalized peritonitis. Yeah. But as I said, that if you don't have a CT scanner, ultrasound, you may want to think about it, yes. Okay. Now, Lee Yi Xin talked about MRI diagnostic for intestinal perforation. Well, that is a wow, because even in our center, UMMC, we do not even do that. Because ultrasound, MRI scan, the first thing is that it's not very easy to perform, because have you looked at how MRI is done? The patient has to be in an enclosed space, right? And for how long? For at least 30 to 45 minutes in a tunnel, enclosed tunnel. Okay, so do you think you got a unwell patient, septic shock, can go for that? Definitely cannot, right?
Yeah, definitely.
So that's how you reason it. You have all the tools available. Yeah, in the UMMC, you have everything, you know. You have MRI, you have CT, you have this and that. But which one is more relevant? Which one that you just think this is a no-go at all?
Okay. Yep. Understood.
Yeah. Yeah. So reasoning skills, again, reasoning skills very important.
Okay. I think it's enough about investigation. Anything you'd like to add first, doctor?
Nope, not so far.
Okay, so I think we can move on. So I have two pictures, one of the abdominal x-ray. There's no pneumoperitoneum for the chest x-ray. So let's move to the next slide, please. Okay.
So hang on a minute.
Yeah.
Chest X-ray showed no pneumoperitoneum. Do we think that perforation is excluded?
No, definitely not.
So what's the percentage of perforation that would have air under the diaphragm? So for example, if you 100 patients that with perforated viscous, how many of these patients that would have air under the diaphragm? Something to look for, isn't it? Something to look up in the literature.
Yeah.
Then you understand why in clinical medicine nothing is 100%.
Okay.
Yeah. So it's a homework for you guys. If 100 patients with perforated viscous have chest X-ray, erect chest X-ray, how many of those 100 patients would have air under the diaphragm? Okay. So
Yep.
it's well published in the literature. You have to know all these numbers and figures.
Okay. Okay. So next, we just look at the X-ray lah. So this is the abdominal X-ray, and this is the axial CT view. Okay. So I didn't take this from the patient lah. This is from the from internet. So but it's pointing towards the diagnosis lah.
What's the diagnosis?
The diagnosis, by the way, is actually ischemic colitis. So something similar to mesenteric ischemia lah. Yeah.
It's not this patient.
What?
It's not this patient.
Not this patient.
It is not your patient.
I'm not sure about that because this one actually, I got it from the ward. They already ruled out everything already. So just waiting for the. So can we just go to the next slide? That's the management. So actually everything was done. So they did a CT angiogram, and then they just found that the blood supply to the splenic fracture of the colon was compromised, and then they want to do surgery to relieve the to do surgery lah for the condition. So they say it's ischemic colitis. So that's why I can get to see it at the ward. So yeah, it's not perforated for some reason. I also thought perforated. I was like, hey, why this patient perforated? Wow, abdominal swelling and everything, and then
Okay, so so how this is what I mean by, you know, when you take the history examination, it might not mean that you get the diagnosis correct.
Yeah.
Okay, but it doesn't mean that it's all terrible. It's all, you know, you haven't been able to you know to be competent in certain areas. It doesn't mean that. You understand? Which is why you need investigations to back you up. Okay, so that's what I mentioned earlier. So if you have not made the diagnosis correct in the beginning, it doesn't mean that you are not competent, or it doesn't mean that you're lousy. Yeah, because that's all the clues that you've got. Yeah.
Yep.
So that's why, you got to be able to reason. How did you get to that conclusion at the end? Okay. But if you have taken that history and examination and you're telling me the conclusion at the end is mesenteric ischemia, I'll be asking you, so in what point of the history and examination you think that's mesenteric ischemia? Yeah. And if you can't back it up, then it's a fail.
Yeah.
Even though you got the diagnosis correct.
Because you've probably seen the MR, the EMR already, then you just
Correct.
seen the patient before.
Yeah. Yes. Or sometimes, you're given a well patient already. Okay. And the patient may tell you the diagnosis straight away. Oh, I've got this. Okay. And then you go relax and not really asking the real clues. How do you get to the diagnosis? So when we ask you to present the summary at the end, you somehow simply put in certain facts, and then your conclusion is what patient tell you the diagnosis. And that's also a fail.
Yeah.
Okay, so you have to understand the process has to be making sense when you make the conclusion. Okay.
Okay. So I think that should be all. Anyone have any question or anything you'd like to add, doctor?
Anything I'd like to add? I think I've said enough.
Yeah. Okay.
I don't know
okay.
if my approach is a bit different for you guys, but generally this is what a practicing clinician should be working on when it comes to the real world. Okay. And a lot of people saying, oh, we at your level you should be just learning the basics. But to be honest, learning the basics, if you don't know how to use that knowledge, it's pointless. Because your brain's only so much you can remember, and the principle nowadays in medical school undergraduate teaching is to be able to reason, use the knowledge to apply. Yeah, it's not about, yes, in this abdominal pain we can do blood test, CT scan, ultrasound, blah blah blah, so many. You give me the list, I would ask you to pick one, and you got to be able to reason me which one you want to pick. If you cannot pick one, it's still a fail. Even though you read the book, you memorize everything, you give me the 10 things, it is not like that. So we don't want to produce students who just follow book by book,
Yep.
Because that's never what it is in clinical practice. Yeah. So try to focus on reasoning for every clues, every investigations, every management plan. Try to ask why. Why do we do that? Why do this clinician choose to do this? Why we, when the patient come in, we do that? Why after certain things we do the other thing? So keep asking the why. Then you know that reasoning skills. Ask when you come to the ward. Ask the houseman. Ask the MOs. Why in this patient you choose to do this? Why not others? Yeah, because it seems that at the moment what we're facing is that a lot of the junior doctors, they follow instruction only. They are not really using their brain to reason. So when they go for postgraduate exam, that's when they start struggling, because they don't know how to reason. We ask them to present something and everybody gets a bit stuck, don't know how to defend. Yeah, so it has to come from beginning at your level, and it will get easier.
Yeah.
Okay, that will be my advice, to start from the beginning. All seems difficult, but actually not that difficult if you do it.
Yep. Okay. So I think that should be all. If anyone has any question, ask now. Otherwise, we're going to end the session. Anyone? Okay. So no one.
Sorry, doctor.
Okay. Yeah.
Yeah.
Yes, sorry, doctor. Just a question to doctor. Actually, clinically, can we differentiate between a mesenteric ischemia and ischemic colitis? or any other history that we can differentiate between them?
Yeah, so mesenteric ischemia is probably one of the difficult one to work it out clinically, whether it's from history or examination, because they usually present quite atypically. Yeah, it can be this or can be that. Okay, so if you ask me, can we really differentiate? The answer is no. But can we have some clues to point towards that? Then yes. So the clues that I mentioned, that risk factors are very important. So people don't just come with mesenteric ischemia. There must be some predisposing factors. Yeah, like heart disease, generally the vessel disease, vascular disease, or atrial fibrillation, heart problems, or thromboembolic history. Yeah. So for example, if this patient previously had embolic stroke or embolic ischemia to legs, then you got to think already, could this be also embolic mesenteric ischemia? So all these are risk factors that you have to think already. The patient might not volunteer to tell you that. Okay. So focus history. Examination, it's very generic for mesenteric ischemia. But like I mentioned earlier, if they are in a very initial stage of ischemia, then they generally do not lie flat. They just move around a bit in a lot of pain out of proportion. Okay, so these are the potential clues that more likely point towards mesenteric ischemia. Okay, but the only way to tell if it's mesenteric ischemia is CT. But CT might not again give you the 100% clue. They might just say to you that the bowel looks a bit distended. The blood flow, it's suspicious but not so sure. Yeah, so CT may not always give you the confident diagnosis unless it's in a very late stage when the bowel has infected, because when they do a CT scan, they give contrast, yeah, intravenous contrast. So when it's infected already, no blood flow at all, completely cut off, and the bowel also looks very edematous and not enhancing. Yeah, so that's when the CT will tell you, okay, that bit of bowel looks ischemic or infected, so become more confident. But in the initial stage, it might not be that apparent on the CT either, unless you do certain different phases of a CT, or we call it CT angiography. There are many different types of CT also, which is why it's very important when you request, you got to tell the radiologist, what are your differentials? If you think that mesenteric ischemia is one of your top differentials, then you tell the radiologist, and they might give the contrast, and they might then do the scan in different phases. Yeah, so arterial phase, arterial venous phase, and the venous phase. There are many different types of CT. So it still comes back to you as a clinician. Where in the history and examination are the clues that point towards the differential? It still comes from you at the end. Okay.
Good morning, doctor. Doctor, if this is the case of ischemic colitis, so what is the association of his hypotension with this case?
So that usually means that this patient probably has infected the bowel. Yeah. So when there's bowel infection, what happens is that they go into sepsis, isn't it?
Okay.
And sepsis, multi-organ failure, septic shock.
Oh, okay.
Yeah. So sepsis is a generic presentation. Yeah. So any severe condition in the abdomen, it can lead to septic shock.
Okay.
So septic shock or sepsis is not a diagnosis.
And okay, doctor. Also, I'm not really sure, but doctor, would you consider intestinal lymphoma in this case?
Okay, so then you have to understand, how does intestinal lymphoma present, and what are the consequences? What are the presentations, or what are the complications that come with intestinal lymphoma?
Oh.
Okay, the intestinal lymphoma can usually come with obstruction, right?
Okay.
And occasionally perforation.
Mm. Mm.
It depends where the lymphoma is.
Mm.
Yeah. So it's in the exam, you cannot tell me this patient has perforation because of lymphoma. But where in the history that you think this is lymphoma related?
Not really. If it's lymphoma related history, should be B symptoms, right? Like fever, weight loss.
Well, that usually means the history is, or the presentation of the history is usually very prolonged.
Mm.
Yeah, they have months and months of something's not right, weight loss, night sweats, intermittent fever, you know. They have months of history, something's not right, before they even develop the complication of it in the abdomen.
Mm.
Yeah. So that's what I mean by the history. If they give you a very long history of something's not right, then you got to think already, what else can it be? What are the list of potential differentials that can come with it with a long history?
Mm.
Malignancy is one of it. Yeah. So malignancy come with, like you said, lymphoma, yeah, or TB. So these are prolonged history of problems before they results in the complications.
Mm.
Okay.
Okay.
But if there's no such history of long history of problems, then in your summary, don't say that, don't say TB related bowel perforation or lymphoma, because there's nothing in the history points towards that. Everything is very short.
Mm.
Then I'll be very worried when you say that already, because clearly this is something you read in a textbook, but you haven't been able to synthesize the clues,
Mm. Okay. Thank you, doctor. Thank
No
you very
problem.
much.
Okay, so anyone else like to ask? If not, I think it's already 11:25. Sorry, doctor, a bit.
It's okay, no worry.
Okay, so last question, faster. Anyone wants to ask? If not,
Hi, doctor.
Yes.
Doctor, may I ask, before we do the investigation, can one of the differentials be diverticulitis?
Okay. So if I may ask you, which bit in the history and examination point towards diverticulitis?
Pain, because there may be perforation which causes peritonitis from the diverticular abscess that may form because of his age.
Okay. So what do you think you need to ask if you think diverticulitis perforation could be one of your differentials?
Maybe bleeds,
Yep,
diverticular
bleeding.
bleeds.
Yep. Anything else?
Constipation.
This patient has 1-day history of bowel not working. Okay, it's not
Low
constipation.
fiber diet.
So that's what I mean by, if you think, from that clues that diverticulitis perforation is one of your differentials, you have to think already, what do people with diverticulitis or diverticular disease normally suffer from symptom-wise? Before you can even think about, could this be your differentials at the end when you summarize it?
Okay.
Yeah? So it doesn't mean that your differential is wrong, but how do you conclude that this is a reasonable differential? That's what I want you guys to, the take-home message is that. So if you think diverticular perforation is one of differentials, history, it should be whether there is intermittent PR bleed, there's erratic bowel habit, off and on diarrhea, off and on constipation, intermittently crampy
there be a
abdominal
mass?
discomfort. The mass usually it's already, a very long history. Yeah. Remember, it goes back to this patient had 1 to 3 days. Very short history. Epigastric or dyspeptic symptoms. It's all up at the top.
Okay.
Yeah.
Yeah.
So that's what I mean. That how do you then say diverticulitis is one of differential? So I need you to reason it. Where do you think in the history examination diverticular perforation is a reasonable differential. If you can't
In
even find that clue, don't even mention it because that will be wrong.
Okay.
Understand?
Yeah.
So it's this reasoning skills, it's a thinking process that you all need to go home and start doing it.
Sure. Thank you, doctor.
Okay, I said last question, right? So I think enough really lah, for this. Okay, so I just like to thank Dr. Ang for spending so much time with us. It's been very helpful learning. Okay, so just thank you lah. Thank you, doctor.
Thank you, doctor. Thank you.
Thank you, doctor. Thank you, doctor.
Thank you, doctor.
Okay, so I think should be all. Okay, so there is a there's another session on Saturday, so just remember to attend lah. Okay, so I think that's all. Okay, thank you, doctor, so much.